Sungai Buloh experience and updates from none other than our ID consultant physician, Dr. Dominic Singh Lim Heng. So without further ado, Dr. Ben, please go.
Thanks, hello. Is there a switch? Oh, sorry. Hello. Thanks, Dr. Afiq. Thanks, Dr. Chua. So I'm sitting here actually, that thing like, talking about the reason why all of you can't sit nearby each other. Okay. So this is what Dr. Sarah gave me, the new norm SARI of COVID-19 approach and management sharing the Sungai Buloh experience and updates. This is by far the longest topic, the longest title I've ever been given for all my talks. So actually, I didn't understand the topic, so I just broke it down according to myself, and I just thought I'd give an overview of COVID-19, okay, overview of COVID-19, and it's actually really difficult trying to compress these 9 months of headache into a 40-minute talk, okay. But broadly, the things that I will be covering will be transmission of COVID, how we diagnose COVID, and the clinical presentation, and the risk factors of severe disease, and then different phenotypes of COVID and the treatment. I may not be able to go into detail about the treatment because I don't think there'll be time. Okay, we'll concentrate on the other things. Okay, another 2 further notes is that my slides are mainly stolen from this website called Clinical Care Options, which gives very, very good slides and very up-to-date ones, and also my boss, who is a very good speaker, but he's a lousy boss because he was supposed to give this talk and he delegated it to me. And the other thing is that it's also important because I think COVID-19, the evidence is coming in fast and furious. And when I look back at my previous talks on COVID-19, what I spoke about in June was no longer relevant. What I spoke about in August what needed to be updated. So really, a lot of the things that I present now, they are accurate based on evidence that we know so far. All right, and things can change. Things will definitely change, okay, in the weeks and months to come as well. And so I know, 3 months from now, I'll look back at my slides. I can't believe I said that. I can't believe I told everybody that. That because things would have been completely different by then. Anyway, what we do know about COVID is what we see in the red here, okay. It spreads mainly through contact and droplet route, okay, which is why that ruling about 1 to 2 meters away from each other, and why wearing a mask. Now we know that any type of mask will help in preventing you from getting COVID, okay, and of course certain types of mask may be a bit better than others, okay. But what I'm wearing now, the surgical mask, which is I think a lot of what you are wearing, is probably the best, okay. It strikes the balance between what's easily available and what's effective. So if you compare this surgical, there was one study that actually compared surgical masks and the loop. I know some of you are also using the mask that is just tie around the ears. So apparently there was one study that actually showed that compared to N95, this mask that you tie at the back, a 3-ply surgical mask, gives about almost 80% protection as what the N95 mask would give, and those that loop around the ears, because it is not so well fitting, actually gives only about 30 to 40%. Okay, so it's actually not comparable to the mask that we tie around the back. Okay. But having said that, we know that any type of masks is actually nowadays helpful both in terms of preventing you from expelling virus if you've got asymptomatic COVID or you don't know that you're walking around with COVID, and of course if you are exposed to COVID as well. Okay. Um, in fact, there's one. Sorry, these are all not in my slides. There's one recent study which is actually quite interesting. They introduced this term called variolation. Variolation is a very ancient term in infectious disease that talks about. Okay, so we all know about vaccines. We all know about vaccines. Okay, so vaccines means you take a virus that is dead or that is attenuated or that is or something like the same virus. Okay, you put it into the body so that the body can come up with antibodies, and then after that, then when they are exposed to the real thing, they can mount the antibodies straight away lah. But there's another term called variolation. Okay, and variolation actually means taking just a little bit of the virus, little bit of the same virus, not attenuated, not killed virus, gives you a little bit of the virus and put it in your body. And then because the inoculum is smaller, the theory is that you get only a mild disease. But by getting a mild disease, that protects you in the future from another serious one because your body already exposed to the mild disease. So once it's exposed to a mild disease, then the next time when you're faced with the same antigen, you can already mount antibodies. So they term this variolation. The reason why I'm bringing up variolation now is because there have been some indirect studies that actually show that if you wear a mask, then the chances are that if you you kena COVID also, you will get only a mild form of COVID because the amount of inoculation that you receive into your body is small because of the mask that you wear. And because the amount of inoculation is small, you get a mild disease or asymptomatic disease. They have tried that on animals and they found that in animal studies that's the case. And on some population studies also, they are finding that when people wear masks, the percentage of people that come down with severe in populations, and they have to study large populations, and then they found that when people wear masks, less percentage of people come down with severe illness. Okay, so there may be some data that we'll be seeing with that coming out. Okay, number one, less people will get COVID, and number two, if less people and the people who do get COVID, less of them will be severe disease. All right. There was a lot of talk about airborne spread of COVID, and there were some specific studies that actually did strongly suggest that COVID can spread airborne. Airborne, that means no point sitting 2 seats away from each other or 3 seats away from each other. If definitely got COVID, you sure kena also. That's the implications of something being airborne lah. Okay, yeah. And there's no doubt that there are certain, I think many of you would have seen, studies because it came out in the popular press as well on the restaurant in China who are, the first sit near the aircon and then downstream further away from the aircon, other people in other tables also kena. Those who are out of the stream of the aircon didn't kena. Okay, there's another study in buses and all that also show the similar thing lah. Okay, but by far and large, we find that airborne transmission is actually quite rare. Okay, quite rare. It is possible in areas where there's poor ventilation, example auditoriums, so the longer you sit in a place with poor ventilation, and of course, if the person is coughing away and spewing out more virus, then there's a higher risk of the thing being airborne. Okay, yeah. And it can also be found in urine, in feces. Quite interestingly, some countries are actually testing their sewage water for COVID to see whether the certain population. So if you stay in a population and you think that, okay, today I want to run off to Pahang because Pahang got no COVID. Pahang has been green for the last I don't know how many months. We go and check the sewage water in Pahang and see whether got any, but we are not so sure, because they didn't test everybody who lives in Pahang every day, whether all of them have got COVID or no COVID, man. So you go and check the sewage water and see whether you can find any traces of COVID in there. Okay, because COVID does come out in the urine and the feces. Now, when you read studies about where COVID can be found, just because they tell you that it can be found on the table where the patient is, on the doorknob, or on the air that was sampled from the room where the patient was in, that doesn't mean that that you can get you will get COVID if you breathe in that air. Okay, and because like all infections, you need to breathe in, you need to take in a certain critical mass of virus. The inoculum needs to be big enough for you to kena the disease lah. So if the inoculum is too small, it doesn't cause any disease at all. So just because you get PCR test positive and this thing, that thing, it doesn't mean that those are infective. That leads to infective dose going to people lah. Okay, yeah. Sure, that was only my first slide, and I got 80 slides. Okay, so predominantly by coughing, sneezing, or talking, and that's the main route of transmission. Airborne transmission suggested by multiple studies, but still frequency is actually unclear in the absence of aerosol generating procedures. So if you work in hospitals and you do aerosol generating procedures, you're intubating the patient, you're giving the patient nebulizers, then different matter. That one, please consider. That one, you have to strongly think that this person can have aerosolization of the virus, so you need to wear an N95 mask in those situations. Okay. The virus is rarely cultured in respiratory samples more than 9 days after symptoms onset, so it does. So later I'll be talking more about that. The PCRs can remain positive up to 3 months, but in terms of whether the virus is viable or not, now we know in most patients, in patients who are mild disease, above 8 days, 9 days, they are no longer transmissible. Okay, but in severe disease, we are not so sure yet. We think it may be go on up to 20 days. So patients in ICU and all that may still have culturable virus beyond the 9 days. Okay, but for mild disease, 8 days, 9 days, over. You can't transmit anymore. Okay, so reduce infectivity. Okay, I mentioned about that. Okay, so the timing, the other thing is when can people transmit COVID? So we now know that in the beginning it was hotly disputed. It was argued a lot about, but now we know that if I'm exposed to COVID today, okay, today Saturday, on average my symptoms will start 5 days later. Okay, so my symptoms will start anytime between Tuesday to 5 days. 5 days, that means 3 days will be Monday. Okay, day 1 today, day 2 tomorrow, day 3 is Monday. So anything between Monday to Wednesday, that's when most people will get their symptoms. Between day 3 to day 5, their symptoms start. But we know that even 2 days before your symptoms start, you already can spread COVID. But I felt okay. I felt completely okay. Wasn't coughing, wasn't sneezing, but they know that can spread already. Okay, there have been enough studies that show us that, and it is not surprising because that's the case in influenza as well. Okay, so people can spread it when they are asymptomatic. People can spread it when they are mildly, when they are pre-symptomatic, before the symptoms start. Okay, but the extent of the spread from these people, we don't really know yet. Okay, yeah. So based on systemic reviews, meta-analysis, asymptomatic spread ranges anything from 6 to 41%. Okay, here it's 0 to 2.2%. So different studies give you different kind of estimates for how transmissible you are. But we know that the main time you can transmit is around the time when your symptoms start. Okay, so your symptoms can start anything. So the incubation period is when you expose until the time your first symptoms start. There's anything in 14 days. Okay, yeah, that's why the incubation period we always say is 14 days. But most people by day 5 the symptoms would have started. And when your symptoms start on day 5, it was around then that so 1 day before that, 1 day after that, that's the time when maximum you can spread to people in your house, people in your workplace, people in your hospitals. Okay, yeah. Anytime from 2 days right until 7 days after your symptoms start. Yeah. Okay, so I mentioned about so this was a interesting study. This was in early in the so you want to study transmission, you can't go to US and study transmission. You can't go to India and study transmission now because there's so much transmission everywhere. You don't know who gets it from who and how did the person get it. But if you go very early into before the outbreak happened or in a place where there's no outbreak yet, so that's how they studied this in China, and they found that two bus loads. So there were 128 individuals. They took two buses, 68 of them in bus one, 60 of them in bus two. They found out that uh, which one was it had the positive patient? I think bus two had the positive patient, and they found that people in bus two, even though they were sitting very far from him, also kena COVID lah. So this study showed us two things. One was that even though the fella sit more than 1 meter away from the fella, but because it was in a closed place, it was in a bus, they were all sharing the same air together, COVID spread to people sitting far away as well. The other thing that this study actually showed was that compared, so the two buses went there, the other bus, nobody got COVID one. So then they went there, then they all went to the same place together, which was an open air place, and then they mingled there for 1.5 hours. The bus ride itself, I think, was 1 hour. Okay, and then, oh sorry, 100 minutes, and then they attended a 150-minute worship event. So they were together, the two buses were together for 150 minutes, longer than in the bus, but that one was open air. And in the open air, I think very few of them got it. I think only 4 of them got it. I can't remember the details already, but very few of them got it. So this also told us that if where you are is an open air, if you can remove the roof of the auditorium, then much safer. Okay, yeah. Too late already, studies that actually show, but this one is in places with high prevalence. I know all of us, cannot tahan sit in the house, wear mask, cannot go here, cannot go there, and all that. What exactly can I do, and what exactly I cannot do? When I in Malaysia and this study, but this is in the US where there's a lot of transmission at the point that they showed that. There are certain things that are probably a higher odds ratio. If you go to a restaurant, you go to a gym, then the restaurant is not like mamak, then the restaurant is closed space and all that. Okay, and then gym, or you go to a bar or coffee shop, and if you go to a religious gathering. But in terms of clear cut risk, is actually restaurants. That one, the confidence intervals are cross one. Okay, so if you go to a closed up restaurant, because that's where you take off your mask and all that, that's the highest risk. And so every now and again, my kids ask me, go out makan, go out makan. I say, must be open air place. Okay, I won't bring them to somewhere where I got. This was a recent study in Hong Kong. What happened was that so when the slide all very messy, this one, I made one of these slides. The one nice ones are all from my boss. So this one was a patient that got admitted into Hong Kong. He had COVID. Nobody knew that he had COVID at that point, and so many of the healthcare workers were wearing N95, but some were only wearing surgical mask, and the patients around the patient was wearing surgical mask, not all the time. Okay, and they actually found that even though they were all together, but if they use basic things like wearing surgical masks, hand and environmental hygiene, actually none of them got it. So the while there can be aerosolization of COVID-19, it doesn't seem to be a frequent event. Okay, and it seems to be if you wear the protection, then it doesn't happen. Okay. So I mentioned about this mean incubation period is 5 days, and symptom onset for 97.5% of them by day 12, they will get the symptoms. This is antibodies. So there's a lot of talk on antibodies that you read in popular media as well. How long do my antibodies last? And there are people that say that your antibodies will only last for a short time. This was a study done in Iceland. They actually tested the whole of Iceland. I mean, they did sampling, not everybody got tested, but a huge percent of the population was tested, and they covered the whole of the island of Iceland, and they actually found that the antibodies actually do last for a long time in the body. This was up to 4 months, and At first, you see a very steep, you take here, antibody level very high. You take here, antibodies levels have dropped so much. So based on this, many people think that antibodies don't last very long. But actually, there's this long-lived plasma cells that actually continue to be able to produce antibodies for a long time, at least for 4 months. Uh, Another messy slide. This was in a fishing boat. Because the other issue about antibodies, and just because you got antibodies doesn't mean you are protected from COVID. Because even if you got antibodies, because once you are exposed to a infectious agent, your body produces all kinds of antibodies. The antibodies all are to different parts of the virus. So it doesn't mean that if you got antibodies means the antibodies can protect you from getting another infection. You need what we call as neutralizing antibodies. That means the antibody, good quality one, it can block the virus from attaching to your ACE inhibitor cell. Your ACE2 cell. The COVID likes the ACE2 receptors in the respiratory tract. Okay, so if you can block it, then they call it a neutralizing antibody. And so this study was quite nice. It was people went on a fishing vessel, and all of them were tested before they went on the fishing vessel. All of them were negative. Okay, and 6 of them had antibodies to 6 of them had actually antibodies to COVID. That means they kena COVID before. All right, and went for a trip and a massive outbreak. 80% of them kena COVID after that, and they found that the 6 of them, 3 of them kena, 3 of them didn't kena. Okay, but the 3 who kena actually, when they look at the antibodies were not neutralizing antibodies. Okay, but the 3 of them who had neutralizing antibodies didn't kena the COVID. Okay, yeah. So if you having antibodies to COVID, tak cukup. You need neutralizing antibodies. And if you have neutralizing antibodies, it seems to be protective against getting that same kind of COVID. The reason why I say it's the same kind of COVID is because they have some reports now that have come out that if you are exposed to a different strain of COVID, okay, then you can kena again. All right, there has been at least 2 reports, one in Hong Kong, one in I think UK, confirmed that this person had 2 different clades of COVID, because COVID is a RNA virus. We all know RNA viruses, when they multiply, they actually produce all kinds of funny mutations when they multiply, and by chance, some of the mutations will be more effective than others in spreading. So this guy was exposed to 2 different clades, and he actually had a reinfection from COVID. When it comes to testing, this recently came up again. I don't know whether the person who tested me for one of my 2 tests, I'm sure when I went, I had 2 testing for COVID. One of them must have done this, and one of them must have done this, because the one that did this was, you're bloody uncomfortable, and made me start tearing and all that. Okay, the angle of the swab was wrong. You actually have to go along the base and target towards the external orifice of the ear. Okay, just a point, because if you take the swab wrongly, then actually your nasopharyngeal swab can be falsely. If you look at this, PCR can detect all of this. Okay, PCR can detect all of this. Antigen test, it is as if you draw a line here. It can only detect it above this level. When there's above this level, then the antigen test can detect. Okay, yeah. So PCR, but it may be more reflective of actively replicating virus. Okay, but the other problem that we have with our antigen test kit as well is false positives. Now we are getting more and more reports and more experience that our antigen test can be false positive, and that occurs with any test. Okay, and that occurs unfortunately much more often when you test the community with very few people with COVID-19. Okay, so pre-test probability. Okay, pre-test probability. All right. So let's say any test I do, there will be some false positive. Okay, there will be some false positive. So let's say if I test all of you here for COVID, and here only one person has got COVID, the rest of you all don't have COVID. And let's say this test, the false positive is for every, I don't know how many of you are here, let's say there are 80 of you. For every 80 people, there will be 2 cases of false positive. So then in the end, the 3 of you will test positive, like the one who's truly positive, plus 2 of you who actually don't have the disease will test positive. All right. So then the false positive rate is very high. The false positive rate is 67%. Okay, these 2 don't have COVID, also the test say got positive. Okay, but if the pre-test probability is very high, let's say out of 80 of you, 20 of you are positive for COVID, then the people who test positive is 22 people. So then the false positive rates becomes very low. Okay, because most people who tested positive memang were positive one. Okay, so there's a difference between using a rapid test now in Tawau or Lahad Datu versus using this rapid test now in PJ. Okay, because in PJ, if your test is positive, okay, did you have any close contact? Do you have any, it may be a false positive. Okay, if you don't have close contact, if you didn't have any risk factors, if you're asymptomatic and all that. But if you go to Tawau or Lahad Datu and you test positive, chances are much higher that there's a true positive. Okay, and so that's pre-test probability. Okay, I won't go through this. This is the false positive for RTK antigen is, of course, if the virus tak cukup, like the very early stage of the disease, some people were blaming the government test because some guy flew from KLIA to Kuching. KLIA was negative, reached Kuching, was tested 1 day later, was positive. It can happen lah. Okay, because it doesn't test the virus and the virus is too low in the body and it cannot pick it up. That's not the fault of the test. Okay, then we come to antibody tests. Antibody tests, the reason why we come to antibody tests, because antibody tests are numerous now. So many companies are making antibody tests and very cheap. Okay, but unfortunately, antibody tests for you as a clinician, for me as a clinician, it is practically useless. Okay, because it doesn't tell me in the acute, antibodies come out only 2 to 3 weeks later. All right, it comes out. So by the time any meaningful clinical decision has already been made, by the time your antibodies come out already, no use telling you to isolate. You already spread the disease to everybody. No use telling you, hey, you got risk factor or no risk factors or severe disease, because you already finished already that time. All right. And so antibody studies useful for population studies, and the one of antibody tests useful. But for clinical purposes, okay, yeah. Sometimes only we use antibody tests as a thing lah. This patient is sometimes positive, sometimes negative. And finally, 2 weeks later, we do antibody test, or 3 weeks later, do antibody test, see whether he actually produce antibodies or not. Okay. Okay, I better this. There was this whole thing about I'm not sure whether you all came across it, but immunity passport. People are all, there are many populations understandably are talking about this. They are understandably, hey, let everybody kena lah. How can you go and lock down everybody? People got no job, people cannot leave their house, people let everybody kena lah. After everybody kena already, then you cannot kena again, what? So that's immunity passport lah. Let everybody get COVID, those who die lah. But unfortunately, it also so again, it comes down to the test how sensitive and specific this is. So this is an example that they give. So let's say in this city, there are 100,000 people. Okay, 5,000 actually really got antibodies to COVID. 95,000 actually don't have. Okay, and even if you do a test that is 95% specific, which is a very, very good test, 95% specific. Most tests are not 95% specific. Then if you run the test on these 100,000 people, you find that those 5,000, because it's 100% sensitive test, those 5,000 who got antibodies, all of them you pick up, no? But among those who don't have antibodies, you also pick up 4,750 of them. Okay, so in other words, if you do the test and you got antibodies, actually chances are 50-50 actually whether you really have antibodies or don't have antibodies. So you do a test, got antibody, wow, the man cannot COVID already. Now I can go to stadium, now I can go to makan, now I can go to do anything I want, I can go and visit my grandmother and all that. All. Cannot, maybe 50-50. Maybe you cannot COVID, maybe you didn't cannot COVID. That is if 5% of your population actually have been exposed to COVID before. Most populations haven't even reached this 5% level of transmission yet. Okay, and most populations, even in US, even in many of the European countries, they haven't really reached 5% of the population being positive for COVID. Okay, so antibody passports are dangerous things. Okay, when it comes to COVID, mainly it starts off with upper respiratory tract symptoms. Hey, how am I for time? But it can go on to disturb other parts of the body as well. You know, the neurology. This one I didn't know until I was preparing for a talk recently that I realized that there have been studies actually show young patients get mainly URTI symptoms, but in elderly patients they may not get so much URTI symptoms. It can be fever, fatigue, loss of appetite, and diarrhea. Okay, yeah. So it can be more constitutional. So just because somebody got very minimal URTI symptoms, but if they're elderly, you still can't say that this one. Okay, yeah. This is our own local data where we looked at almost 6,000 of our own patients. Okay, so this one introduces the categories of COVID. Category 1 means asymptomatic. Category 2 means URTI. Category 3 means pneumonia. Category 4 means you need oxygen. Category 5 means you either need ICU or intubation or support. Okay, most patients actually when they came in with mild disease, they remain mild disease, but a very small population of them moved on from mild disease to severe disease. Okay, this one is the group that presented already with severe disease. Okay, so 63 presented with category 5, 210, category 4. This one's about 198, I think, of them were mild to start with, but they progress on to get severe. Severe means category 4 and 5. Mild, that means category 1, 2. Okay, and this is the age-specific mortality rate. Okay, yeah. So I'm approaching this 2% mortality if I get COVID, and if you are more than 80 years old, then your chances of getting severe disease is up to 50%, and the chances of mortality is 22%. The other thing apart from age that stands out is chronic kidney disease. Actually, all of these comorbidities also stand out: diabetes, hypertension, chronic heart disease, and chronic kidney disease. But on multivariate analysis, when you looked at the age and all, then one thing above age that stood out was chronic kidney disease. So people with chronic kidney disease, even if you are young, you can kena severe COVID. This was the risk of getting severe COVID, category 4 or 5 versus category 3. Okay. And looking at blood tests as well, we know CRP levels on multivariate analysis still stood out. And of course, if you have chest X-ray changes, then it stood out as a risk factor, as a risk. Okay. So based on that, we came up with this kind of score, this kind of thing, who gets severe disease. Okay, age more than 50, chronic kidney disease, any of these. This one are all proven in our own local data. Okay, they get chronic disease. If they get severe disease, they get anytime between day 5 to day 10. That's when we. So this is something like dengue. Now we have turned around COVID to look at it something like dengue. Patients go through different phases of the disease. Who are those who kena severe disease? When they kena severe disease, how to know that they are kenaing severe disease now? So persistent symptoms, respiratory starts to deteriorate, CRP is going up, lymphocyte counts dropping, pneumonia getting worse and worse. All right, these are some of the X-ray changes. So patients who get COVID-19, they tend to get a viral-like pneumonia. So diffuse changes in the chest X-ray, and then low lymphocyte counts. Okay, and low lymphocyte counts and CRP levels. Severe disease CRP levels tend to be high, and in mild disease CRP levels are low. So patients go through the viral phase. Some patients, all the mild patients, just go through a viral phase and then no inflammatory phase. So they get away. Just kena COVID, masuk ward, grumble, the Facebook and WhatsApp and that thing all the time. And then after 1 week, finish. Okay, we keep them for 2 weeks, I know, but after that, then everything finished because they never gone on to the post-inflammatory phase. Some people viral response makes their comorbidity illness worse, like chronic kidney disease and heart disease and all that. They can get chronic their disease. Okay, and some of them have a very exaggerated pneumonia, viral pneumonia illness. So they get very little post-inflammatory response, but they get a lot of the viral pneumonia becomes predominant. Okay, so this type of different phenotype actually differently using anti-inflammatory agents or okay. Where am I going? But there are some studies that actually show that IL-6 is not the thing, so the data is still all right. So they've showed it other. This is a trial with tocilizumab, which we also use, and it's something like anti-inflammatory. Okay. All right. So now the recommendation is to use dexamethasone. If we see this kind of picture, the inflammatory response going up, the viremia is already coming down, but the patient is actually getting worse, then we actually use PrEP. Okay. There's still a role for tocilizumab as a salvage therapy. Remdesivir, which we also hear about it in the newspapers, disease. Okay, for it doesn't help for mild patients. Okay, for patients for the 80-90% of patients who have mild disease, and it doesn't seem to help. Okay, but it does help for those who have severe disease. And but if the disease is too severe, it also doesn't seem to help. And there's remdesivir is not the magic cure because there's still a lot of questions unanswered about remdesivir. Early studies on remdesivir show that there's no effect at all on viral load. So no effect on viral load, how does it help the patient? And and we think now that if you want to use a drug that's antiviral in nature, whether it's Kaletra or whether it's remdesivir or now we use favipiravir, you have to use it early in the disease because I told you the viral phase is in the first 7 days. Okay, and so you want to use a drug with minimal side effects, and you want to use it for those who will benefit from it. 80-90% of them won't benefit. You just give them more side effects on the medicines only because either way they get mild disease. So you need to find out who is it. You need to try to predict who is it who will benefit from this disease. You give it early enough. They have to come to you early enough. You have to give it the treatment early enough. Then perhaps you can avoid the response. Hydroxychloroquine now they say is useless. Also shows that actually it doesn't help. I have now used this drug called favipiravir and interferon for the. Okay, so category 1, 2, 3, we don't treat unless yes, category 4. Okay, coagulation also seems to be very important. Okay, now we know that there are studies that show that some people just anticoagulate everybody, and then they find that and there's some other interventions like guidelines in our hospital. Okay, complete rest in bed and self-proning also seems to help. Okay, so in summary, transmission is mainly droplet, but there's limited spread by contact. Airborne can be prevented by taking droplet or contact precautions. Okay, airborne precautions only when aerosol generating procedures are done. The gold standard is still a PCR taken from the correct source because if you have severe disease, you take from lower respiratory tract. I mean, you've got lower respiratory tract disease, then lower respiratory tract will give better yield. Rapid antigen tests are mainly in high prevalence settings, mainly useful then only. And then antibody tests not useful for acute infections. The clinical features are viral-like pneumonia, can be complicated by ARDS and pulmonary embolism. That's the main complications. And the treatment actually depends on the phase of the disease and the suspected pathophysiology. And you balance between using antivirals and anti-inflammatory drugs. Okay, thank you.